We will start at 14:40 as in the timetable. If we start a little earlier, some people may miss some of this part of the session because they're waiting for 14:40. Now I have an announcement. Someone with the car number DFP 350. You've blocked
Health and the local government. So we have mainly 4 programs, and the 5th one, which is in a very early nascent stage, but it is picking up its steam. The first one is on diabetes foot. The second one is on type 1 diabetes, which we have started since 2005. And then we have the National NCD program, which over the last 20 years, we started with the zonal hospitals, with the regional hospitals, with the district, and now we have just completed 700 health centers. And then finally, we have digitalization, which we are looking at how do we digitalize the care and treatment for diabetes and hypertension at the primary care level, right from the community to the dispensary to the health center. And finally, we'll have some presentation on acute management of NCDs, which the program which was created during COVID-19, and we saw that many of the patients with COVID-19 who died or who had morbidity were with those with type 2 diabetes. So we had created a training modules for management of acute non-communicable disease during COVID, but now we called it as any pandemic, whereby we basically provided skill sets to those patients, frontline medical doctors to manage acute NCDs. So can I invite the first speaker? I don't know if it is Philbert who is speaking or it is Dr. Renatus who is making a presentation. Dr. Renatus is the program manager for the National Food Program together with the Type 1 Diabetes Program within the TDA. Welcome, Renatus. Sorry, so we'll have a presentation of 15 to 20 minutes maximum. At 20 minutes, we'll switch off the mic. And then I think afterwards, we'll have a panel discussion where we have a question and answers. So 20 minutes for each presentation, maximum. Thank you.
Thank you, Chair. Good afternoon, everyone. And thank you for joining us today. My name is Renatus, and together with Nyoni, we'll be leading the discussion about the food project, which is implemented by the Tanzania Diabetes Association, of course, and the coordination of the Ministry of Health. I would like, before we start discussing the outcome and challenges of the project, I would like to take the first opportunity to take you through the background so that we can try to understand why was it necessary to have such a project in our country and why is it important. To get started, yes, we are TDA staff and we declare no conflict of interest as we give this presentation. So we understand that the burden of diabetes is increasing, and so we expect the impact of the disease itself, but also its complication to most likely increase. So one of the commonest chronic complications of diabetes, especially type 2 diabetes, is the diabetic foot ulcer, which is a major public health concern among people who are living with diabetes. The prevalence of the condition differs depending on where you are in the world, but it has been established that the global prevalence of diabetes foot ulcer is around 3 to 20%. And one of the studies which was conducted here in Tanzania revealed a point prevalence of 15.3. At diagnosis, it has been established that at least 10% of people who are diagnosed with type 2 diabetes, they present with at least a risk of diabetic foot ulcer, which can be a peripheral vascular disease, or it can be a peripheral neuropathy. And the lifetime chance of developing the diabetic foot ulcer ranges between 15 and 25%, depending on the literature that you are referring to. About 15 out of 100 diabetic patients who are admitted is because of the diabetic foot ulcer, and diabetic foot ulcer actually contributes 40 to 60% of the non-traumatic amputations around the world, and 85% of all of the non-traumatic amputations which people living with diabetes undergo is due to diabetic foot ulcer. So you can see how significant this is. Diabetic foot ulcer affects the different aspects of life. It's economically bad because it's very expensive to manage. It affects the quality of life, but it also adds burden to an already overwhelmed health system like ours. In Tanzania, it has been estimated roughly to manage the DFU, it will cost you around more than 3,000 US dollars. And the other aspects of life which can be impacted or can be affected by the diabetic foot ulcer includes employability, someone becoming dependent, but also it causes poverty because it's too expensive to manage. Now, we understand all of these facts. We understand the burden, we understand the impact of the condition. But we still see that less people have knowledge about diabetic foot ulcer. So many studies have established this. We also understand that very few people do check their feet regularly, like inspect their feet regularly. The study which was done in the US and the UK, revealed that only 33% of the participants reported to have been checked their feet by the healthcare provider. And in Tanzania, one of the studies that was done here in Dar es Salaam, 87% of the participants reported that they have never been checked their feet. They were not inspected by the clinician. Also, studies have revealed that we have we used to have very few healthcare providers who are committed to the care of diabetes foot ulcer. And most of our patients delay in making decisions to seek for medical help. But also we didn't have, or we don't have a good system of monitoring the diabetic foot ulcer to understand the burden and how is it changing over time. So what could be done to change the situation? Several scholars, international and local scholars, they have come up with so many recommendations and strategies of reducing the amputation which are associated with diabetes. And some of these are to raise awareness and educate patients, but also healthcare providers about the diabetic foot ulcer. Establish specific diabetes foot clinics with multidisciplinary team, which involves nurses, surgeons, and physicians. And also incorporate food assessment in routine diabetes services. Make sure that you encourage patients to self-inspect their feet, but also the use of protective foot, which has been shown to prevent diabetic foot ulcer between 60 to 85%. And if possible, countries have been advised to have a project or a specific program on diabetes foot ulcer. So responding to this call, the Tanzania Diabetes Association started the National Diabetes Foot Project. This is a project which is funded by the World Diabetes Foundation. It's part of the national NCD program, and it has so many interested parties, including professional bodies such as the Association of Physicians in this country, but also Association of Surgeons and others. The overall objective of the project is to reduce the limb amputation among people living with diabetes. And the project also, it has its specific objectives to meet, which include to increase the quality of diabetes care and reduce the incidences of diabetes complications, such as the foot complications, but also educate and raise awareness of diabetes complication among patients and the general population. The other specific objective of the project is to capacitate the healthcare providers to be able to review the food services, and also to capacitate the regional diabetes clinics for diabetes annual review. So the targets of the project primarily, as I said, is to reduce limb amputation among people who are living with diabetes by at least 50%, and several other secondary targets, which basically include capacitating the healthcare workers, but also equipping the clinics to be able to do foot assessment among patients, screening patients, and make sure that we provide them with education on diabetes foot care. So to implement the project, the first thing that we did was to form the project team. And here I mean the project management, but also the implementation committee and the steering committee. These are committees which oversee regularly on how the project is being implemented and how it is faring. And then we did the baseline assessment to understand what is the situation before we start implementing the project. So this was done in collaboration between TDA, the Ministry of Health, and the PLRG to understand the baseline situation. And thereafter, we engaged in curriculum development and the accreditation. So several experts and the partners, as well as people of different backgrounds, came together to think, digest, and also develop curriculum on what should be taught to healthcare providers moving forward in order to reduce the limb amputations among people who are living with diabetes. And this curriculum, when it was completed, it was accredited by the Medical Council of Tanganyika, but also the Nursing Council of this country. Then we started the training. We did the training in Zanzibar, and we involved all of the regional referral hospitals in Tanzania mainland, but also we had facilities from Zanzibar as well. But also we went beyond. Although the project targeted the regional hospitals, but we went beyond to involve the zonal referral hospitals, the national hospital, but also other specialized hospitals. After training, there was cascade training at the level of the facility, where those who were involved in the training at the first point in Zanzibar went on to train other healthcare providers at the facility level. And thereafter, we did procurement and distributed the starter kit, the tools which were required or which are required for assessment, but also management of diabetes foot. And these all were distributed to the facilities. With this also we trained and distributed the registry for the diabetes foot ASA, but also other training guidelines. And thereafter, the clinic started operating. However, we continue providing mentorship for most of the clinicians who were trained at the first place. And I can see some of the doctors and the nurses are here attending this conference as part of mentorship, where they come to conferences like this one, hear from experts, get time to interact among themselves, but also with the experts to enhance their knowledge and so that to improve their services. And lastly, we have been conducting support supervision, but also monitoring and evaluation activities have been going on. So how far have we gone? What have we achieved so far? I would like to welcome Nyoni. He will take you through this part of the presentation. Thank you.
Thank you, Dr. Renatus, for a good introduction. Good afternoon, everyone. So my name is Philbert Nyon. I'm also working with Tanzania Diabetes Association, an economist, but also a monitoring and evaluation expert. So I will take you through what we have been achieved so far based on our initiative, especially on strengthening diabetic foot screening at our regional. So here is results, but you may find on the table, this is a number of healthcare providers that have been trained at regional referral hospitals. So we have different times here. We have 2020 and 2021 data collection period, but also we have 2022, 2023 data collection period. 2021, 2020, 2021, it is a baseline assessment, whereas a program TDA in collaboration with the Ministry of Health and the TDA, and a program secretariat, we have been managed to develop data collection tools. That was basically a quantitative tool to have pre-information on what is there at that time before we start our implementation. And 2022 and 2023, here is a result after being implemented our initiative. So basically, based on first indicators on number of SCare providers who have knowledge and skills on managing diabetic foot ulcers, on 2021, on a cadre of medical doctors, assistant medical doctors, and clinical officers, at that time, based on the number of available SCare providers, we were found that only 12 on this cadre have knowledge on managing DFU. But now, after the initiative, we are speaking on 278. These are the SCare providers on this cadre that have been trained. And they have been trained on two approaches. The first approach, the program has managed to organize a national food program training that was held in Zanzibar, where we identified a few healthcare providers just to represent others from their fellows from their facilities. So those who attended this training, when they go back to their facilities, they have been managed to train others. Mostly of the methodologies that they have used to train others was through morning session, or they call CME. So, and that session was based on the cases that they have been identified from the surgical department or from the medical department and from the clinic department. So once they identify, they just take the cases and start to provide knowledge to SCare provided during the CME. So for nursing officers and assistant nursing officers, on baseline, they are on 13, but now we are speaking on 477. But there was also physician at that time. They have physician, but they are not trained on DFU. So, but now we are speaking of 6. So you may be surprised to see the number of physicians. Based on our reality, most of the physicians, you may find most of the physicians in cities. On peripheral, there are few in number. So I also come to surgeons, the same. There are 4, but now we are speaking set 1. They have been also trained on DFU management, the same to orthotist. No one has been trained, but now we are speaking on 12. We had also physiotherapist, where no one, but now it's 11, and we come up with a total of 29 at the baseline, but now we are speaking of 815. So, what has been the achievement after the training? On the graph, you may find diabetic patient on the first bar graph, but also we have number of screening, but also percentage of screening. So on diabetes patient, this was a cumulative number of diabetes patients who have diagnosed at the facility, but also were referred to start receiving a care on established diabetes screening. So on baseline, there were 15,212 patients, but now on 2022, after initiative, there are 11,121. So for screening, because the aim of the training was just also to empower them on how to screen the patient so as to identify complication on foot at an early stage. So you may be see on the graph during the baseline, there were only 3,444 DM patients who was being screened for DFU, which was equivalent to 23%. But now after the initiative, the percentage have been increased. So now here we are speaking on 75 of the patient have been held to screen for DFU. So this is also an improvement as when we compare baseline and the after implementation for our initiative. Also, we have foot ulcers. When they screen, they have found some patient with ulcers. During the baseline, we have found 16% of the patients who have been screened for ulcers were found to have DFU, but now here we are speaking of 14% of those who have been screened for foot complication have now have the diabetic foot ulcers. So here's a rate of amputation, but basically the main goal of this program was to reduce the amputation rate. And this is the main goal of our program. So you may find here on the graph, at a time of baseline where we didn't start our initiative, data that was collected at that period, it was shown that there were 28% of amputation that was being caused by diabetes mellitus. But after the initiative and starting tracking the patient and starting to collect data on the same indicator, now we are speaking on 25% being amputated. So there is a slight reduction of amputation, but we know that we didn't meet our target because we are target to reduce amputation by 50%. So this reduction here, we are speaking of, we have been able to reduce by only 11%. So we still have a long way to go so as to ensure that we are going to achieve our goal. So there is a number of issues that have been found that even we have let us down to meet the target. So here you may find the program goal, percent of patient amputated, baseline it showed 28%. Our target was to reduce by 50%, that means we have to be at 14. So what we have achieved, as I said, so we have now talking on 25%. So what are the challenges? The first one, most of the patients present at an advanced stage of diabetic foot ulcers. This initiative, it is being implemented to regional referral hospitals where they are receiving patients from the lower facilities. So those that are being referred from the lower facilities, they are coming at a later stage. So the most beautiful thing to do with those patients, it is more amputation rather than anything. Also, there are less capacity of knowledge among healthcare providers at the lower facilities, as I said. That's why they are referring patients at a late stage. But also manpower, we had a shortage at DM clinic, especially at the referral hospitals, where the number of patients attended as compared to healthcare provider available, it is quite not equal. So this is also a challenge. But also, most of the patients does not afford treatment and further investigation. So this has also led them to can't afford even to buy a medicine. So that is also a challenge that led them to not control their blood sugar level. Also, there are also some of the patients are not attending clinic regularly. But also, some of the patients are diverging from the clinic and starting attending to local herbs. So once they have attended local hubs, things are going wrong, so they are coming back also to DM clinics, but they are coming at the late stage, so that's why they are being admitted for an amputation. So what is moving forward? So let me again welcome program manager for another.
Yeah, thank you, Nyoni. To just conclude on our presentation, so far, and given the situation that we are in right now, and the challenge that Nyoni has discussed, we think that we needed to complete the development of the education leaflets or materials that can be taken to the level of the community to create awareness, but also to continue providing education, not only to patients, but also to healthcare providers, strengthening data collection, but also integrating the food care data into the existing data management systems. And I think if it would be very important if we can expand the program to cover the primary healthcare level, because that's where the patients are. And as you saw, they delay coming to the hospital because there are a lot of issues going on there, but also the healthcare providers at that level, probably they are not very well equipped to do food assessment and manage the double food ASA. So these are some of the selected references, and these are people who have been supporting us or have been working us to implement this project. And with those, so thank you very much. That marks the end of our presentation.
Yeah. So, having discussed with my co-chair, we thought that it would be better to have 4 or 5 questions after each presentation so that we do not accumulate all the questions at the end, and also taking into consideration the time. So if there are any questions, then the 2 speakers are here. One is our auditor, which is a monitoring and evaluation person, and the one is the implementer. Yeah, please.
Thank you very much. Dr. Susan Nachireka from East African NCD Alliance from Uganda. Thank you, Tanzania Diabetes Association, for the work you're doing in diabetes. Actually, you are the people we look up to in the area of diabetes in Uganda. So, diabetic foot ulcer is a big problem, and the work you're doing is really good. However, you know that with the growing numbers of people with diabetes and with the small numbers of healthcare workers, I think we still see that there's a problem. And lately, health workers are not so much interested in giving patients time. You find that the healthcare worker will spend just minutes, and yet this is a time-consuming exam. I wonder whether this will be sustainable eventually, unless we scale down diabetes care to even the lowest health workers. Otherwise, it may not be sustainable. Thank you.
Any other question? Yes, please. Yes, please, proceed. Professor Swai is here. Oh, okay.
Okay, good afternoon. My name is Dr. Siegfried. I have just a comment. Thank you very much, TDA, for your initiatives of helping to deal with diabetes. As we have seen the data, the success is not that much. What could be the reasons? Is it that the patients are not affording medications, or what? And the other question is, like, did you take into consideration monitoring the glycated hemoglobin of these patients to see whether the diabetes is well controlled or not. Thank you.
Yes, madam. Yeah.
Thank you so much for the wonderful presentation. My name is Kwizera Christopher. I work with Uganda NCD Alliance. Looking at your data and your presentation, and of course the statistics you're giving us, then I went back at home and I realized that almost all the patients the diabetic patients, whether they are seeing the best doctor, or at the end of the day, most of them have developed the complications. And when you focus on controlling the diabetic foot, I would think it's a very good idea. But the best idea, I think, would be to look at the controlling the disease itself, other than focusing on the complication. Because at the end of the day, what I have seen, patients with diabetes develop multiple complications. They enter a hospital or health care facility as a patient of a diabetologist or of a physician. Towards the end, they become a patient of multiple healthcare professionals. They will require a surgeon, they will require an ophthalmologist, they require a neurologist, everybody. So are the diabetologists doing their job very well? Or there's something that we need to do better than that before we look at the foot itself or other complications? Thank you.
Yes.
Can we, sorry, can we have a mic here? I think, are you able to, yeah, okay.
Yeah, I've got it. Thank you very much. I'm Dr. Odette Nyiramirimo from NCD Alliance from Rwanda. I've not been in clinics for more than 23 years, unfortunately. So I might ask questions which maybe many doctors here might find a bit funny. But since we are in this organization to make awareness on how to prevent these NCDs, I was wondering, for people living with diabetes, what could they test themselves? Because you mentioned that people who are having those ulcers of the feet have never been examined. They should be examining themselves, as we teach women to examine their breasts, as people have to make themselves to be taking their own exams to see what would be the complications. So I think people living with diabetes should also know how to examine their feet. What do they find? Do they find cramps? Do they have pains? Because people who are amputated, they will always tell you they've never felt anything before that. So please explain. Thank you.
Okay, last question, if any. Yeah.
Good afternoon. I'm a physician, and actually, Dr. Pale was actually mentioning the question that I wanted to ask in regards to prevention. So it's absolutely crucial to train on how to treat the diabetic foot wound that's already existing, but what exactly are we doing to prevent in terms of footwear, early examination, self-examination? Is this part and parcel of your initiative and your training, or are you just focused on the training, on the treatment aspect? Thank you.
Okay.
Thank you very much for the good questions. We try to answer all the questions as best as we could. So the first question, I think, was on the issue of sustainability. So if you look at our recommendation, we thought that it is very important that the primary healthcare level, and people working there, they are capacitated to be able to detect the early signs of diabetes foot and take appropriate measures before someone develops diabetes foot ulcer. Because developing diabetes foot ulcer is a process. It's something that doesn't just come in a day or two. It takes sometimes. So if these patients who are attending their clinics, their regular clinics, they have the opportunity for their feet to be assessed, to be examined by the attending clinician. This will help a lot to reduce these diabetes foot ulcers. So yes, sustainability is very important, and that's why we suggested that we should extend this program or this kind of intervention to the lower level, so that they are also capable of preventing these ones before they refer patients at the regional level hospital for management of DFU, instead of preventing the condition at the lower level. The third question was about controlling, it's important controlling the condition instead of focusing on the diabetes foot ulcer. So yes, the primary objective of the project, as we said, is to reduce limb amputation, but it doesn't mean that the only thing that we are doing is to wait for a patient to come with diabetic foot ulcer and then manage instead of amputating. So if you look at the project in its entirety, you will see that there are a lot of other activities which are conducted, which means to reduce the risk, but also prevent development of diabetic foot ulcer. So you can see that the healthcare providers which were trained, they were not trained to just prevent amputation, but also to be able to detect the early signs of DFU, early signs of foot complications among patients with diabetes, and take appropriate measures. That's why the project not only trained the clinician, but also supplied the basic tools which are required for someone to be able to assess fit and detect the early signs and take appropriate actions. The other question was about, I think it was not very different from the previous question. So as I said, the project doesn't only focus on the on management of the diabetic foot ulcer, but it also primarily focuses on the prevention of the DFU, early detection. And that's when you see the patients, if you look at the objectives and specific targets that I was mentioning, we want to ensure that the patients themselves, they are capable doing their regular check of their feet. So if you look at the training program, the way it was structured, you will find that there are areas, and there are areas where a patient is supposed to be taught, and there are things which a patient is supposed to be taught to be able to assess his own feet and take appropriate measures, including like daily check of his feet, if there are any skin change of color, if there is any growth or anything that doesn't look normal, the patient should be able to check that and also report to the patient. And the actual studies have shown that 56% of DFU which are reported at the clinic is a patient who first detected the changes and then reported it to the clinician. So we know the importance of empowering the patient, and that's why the project not only focus on managing the DFU, but also capacitating the patient, being able to check their feet, but also take the right actions. Thank you very much.
Okay, so I think it has taken us around 45 minutes for one presentation. And if you go on this way, probably we'll leave at 7 o'clock from here. So I think we'll have to start, because it was the first presentation, probably I gave a bit of a leeway, but I think we'll have to be strict with the time control. Two, I think the question regarding why we started at the zonal level and the regional level was that what we always whenever we are starting any initiatives, we are starting at the highest level because we want those people, when the referrals come from the lower levels to the higher levels, we want them to be able to manage those complications well. And one of the things which we noticed was that most of the surgeons, once they see a diabetic foot or they see an ulcer, they talk about amputation. And some of these ulcers and some of these foot lesions are preventable and they can be managed conservatively. So the reason for starting from the top was to see that when from the lower levels of care, when the complications come in at the regional level are adequately equipped to manage those foot. And as Dr. Renatus mentioned, that if this program is successful, then we'll slowly go down. But at the same time, within our other training centers at the secondary and tertiary and a primary level, we are already training the healthcare providers on early detection of diabetic foot, and also the patients are being empowered to look at it. But if you look at from the patient's perspective, 26 to 28% of the patients with diabetes cannot see, you see, and when they cannot see, they cannot even see their foot lesions. So it is the caregiver who needs to be trained to see those foot and not the patient himself, because patient will never see the foot lesion. So I think it has got a huge complex things which we need to look at, but we need to start somewhere, and that is where we started. So with that one, let's give a clap of hand to Renatus and Philbert. Thank you very much. And the next presentation we have is from Dr. Edna Majaliwa, and she's going to talk about the journey we have had with the type 1 diabetes, how we started the program in 2005 and where we are currently. And I hope she'll just give us a short snapshot. She just finished her PhD, so congratulations, clap. She just defended her PhD last week at KCMC on type 1 diabetes, and I hope she's not going to give us a PhD lecture, but just a short snapshot. Thank you.
Good afternoon, ladies and gentlemen. Thank you, Chair, for the introduction, and welcome all. I'm going to be as short as possible. Okay, so I'll be talking about type 1 diabetes program in Tanzania. This will be my outline. I won't talk much about the definition and what it is, but it's mainly the type that you find in children, though everyone is affected. And you can see in the burden, when you look at the blue lines, you find that Tanzania is among those countries with low incidence of type 1 diabetes. And if you see in this chart, it's about 1.8 to 1.9 per 100,000 population. That is the incidence we have. But when you compare to Sudan and Eritrea, they have higher incidence. And when you compare to the global, with the Finland with the highest, that's 52. So we're wondering, why do we have the low incidences? Are we still undiagnosing a lot of children? And do we still misdiagnose? Do we have high mortality, or are we genetically protected from type 1? And most of our studies are mainly hospital-based. So this is the annual incidence. As said, we've reached at 1.8 to 1.9 per 100,000 population. And these are the numbers of children we have. We're at around 5,000. And in Tanzania, we have two programs. We have Changing Diabetes in Children, which started in 2009. Initially, it started in 2007 as Tunza Watoto program, and it started in the zonal hospitals. But then we have Life for a Child, which started at IDF, Child Sponsorship Program, which started in 2005, and it started in Mumbai National Hospital. Now we have about 39, and we're going further. When you see, it's like throughout the country we're covered, but we've not reached the lower levels. Most of them, it's either referral regional to some of the districts. So some of the districts have not been reached, but with the national diabetes, type 1 diabetes, they might be covered soon. So what we've seen so far for the measurable outcomes, the number of children have increased. But then the number of acute complications have reduced. Not much, but I'll take an example of DKA. It was 90 at diagnosis initially, and now we've reached at 38 in 2020. We might be less than that now. And when looking at other complication, retinopathy in 2005 when we were starting was at 22.6%, but we are at 10% now, and neuropathy is 29. Nephropathy is still high, 29.3. And our glycemic control is not good, but we are at least at between 10 and 11. So what is going on currently? We're expanding our services through type 1 diabetes national programs. We're trying to classify type 1 diabetes genetically and find out if we are similar to other societies and races, and mapping the incidence of type 1 in the country. We've had type 1 diabetes management guideline, which is already in use. So we have then the guideline and SOP. And one more thing I didn't say, we've reduced mortality from it was at 6, now it's around 2%, and the survival was at 59. Now it's at least at 69. We're not that far, but at least we are moving. And we had a lot of loss to follow up. It was about 35%. We've not gone far, but at least now we are at 29%. And the challenges that are common challenges that many type 1 diabetes faces, but in our society we have high mortality. We still have high loss to follow up. 29 is still high. Poor glycemic control. 10 to 11 is not a good control at all. So we're still at a high risk of chronic complications, and we lack psychosocial supports. The health capacity challenges and the impact of other communicable diseases, there are other historical reasons for challenges, and there are other challenges. So when we say high mortality, our patients come late, probably because they're unaware, but then probably because they're staying far, but they're also herbal medicine, so they have to try first before they come to the hospital. So there are also myths about diabetes. Till today, many people don't believe children get diabetes, even in the urban areas. If you ask, most do not believe if children have diabetes. So poverty, which you can't run away from, is part of why we're getting the high mortality. The healthcare providers, even in parts of some healthcare providers, do not believe children get diabetes, so they might misdiagnose them. They won't think of diabetes the first time they see a child, and so there's lack of an awareness and lack of management. So there's mismanagement and misdiagnosis. Then there are complications of management. When we come to psychosocial support, we do not really have a specific person to give that psychosocial support. So whoever is seeing a child has to do everything from giving medication to psychosocial support. It might not be well laid. And so it's mostly given by an assistant educator and doctors. So we don't have a well-laid structure, as I said. So at family level, sometimes children when are brought to the hospital, it's like been left for the hospital and they won't get support from the family, so we lack family support. It's worse when they're adolescents, and adolescents is a time when people are trying many things, even when they're not on diabetes, but they try many things. So in type 1 diabetes is even worse. Sometimes they miss the medication, they drugs, and sometimes other care needed. So we lack support from parents, and we lack support from the other
people who are around them. We have high rate of loss to follow-up with the difference, but still high. And this leads to deterioration in control, which means our chronic complications are so close to us. And we also have high rate of complications. I think it's 38, but 38 is still a lot of people. And why do you have this challenge? Probably because some people are very far from the clinic, so the distance is adolescent friendly clinic. And when we look at our mortality, most of our deaths occur between 17 to 22 years. When they cross that, most of them survive. So it means there's a gap in that age category that we have to tackle. So our patients also develop chronic complications very early. As we've seen, the retinopathy and nephropathy, they're very high. So is it the care? Is it an awareness? Is it our genetic makeups? Probably. Do we have providers and also in children themselves? Frequent CMEs regarding diabetes in children, they also help awareness. The guideline, which is done already, not underway, is available now, and the registry that is underway, it's there, but it's just not been given out. And the more clinic with the national type 1 diabetes program. I think that those are things that are going on to try to tackle some of the challenges. And this is the very, very first clinic when we starting in 2005. And now these are different people in camps, different adolescents and kids in different camps where they do training and other life-saving skills. So we need more awareness, more training, more data, more research. Together we achieve more. Asante sana.
Thank you very much for keeping time. Any questions? No questions? Crystal clear? Yes, Mads.
Thank you very much for this presentation. I had a question to detection. In terms of, I know that it's a challenge, as you also pointed out in your presentation, that many of the type 1 patients that are diagnosed, show up or are diagnosed at a late stage, and probably also many are misdiagnosed. So have you seen over the course of your program that you've been able to improve the detection rate, or that some patients are identified at an earlier stage?
Thank you for the good question. On detection, there's more awareness now, and we have less DKA at diagnosis. Like I said, we had DKA at 89.9%. Now it is 38-point-something%, which is lower. So many don't come in DKA, they come with classical
symptoms of diabetes, yes.
Thank you for good presentation. I don't know if I followed well. My first question will be, is this a government-sponsored program or it is for Diabetes Association of Tanzania? And if it is so, I know most of the countries where they support, solely someone is sitting besides me, there is no continuum of care. When a kid reaches like 21 years, then the follow-up and the free treatment and the free checking, which is asking, stops there. Do you follow them to see what is happening in the community, or you just leave them where they are? You stop on 21 also for these kids, which really you have started with them while they are young until 21 years. So what happens there? Do they go, do you integrate them in the already health system? Or it's what you are asking yourself? I saw so many questions you're asking yourself. So I think you should tell us those questions you are asking, what is being done, at least in Tanzania. Thank you.
Thank you for the good question. At least the why and where's and how I've tried to answer them in the presentation. So for the programs, I say we have 2 programs, but they're working hand in hand with Ministry of Health. It's Life for a Child and Changing Diabetes in Children in a collaboration with Tanzania Diabetes Association, but with the Ministry of Health. So most of the things are starting at the Ministry of Health, and that's how we go to other areas so that we can have sustainability of these programs. And so the 2 non-governmental, they are international organization, and Tanzania Diabetes Association is non-governmental, but then there's the government within it. And for the age, we stop at 26. That is where the program is supposed to stop, but there's a follow-up that will happen in between 26 and 30. That is where the discussion is, and see how we're going to manage this one after 26 years.
I also have some questions for you, Dr. Edna. Thank you for a wonderful presentation. My name is Lucy. I'm from Nimri, Mbeya. My first question will ask about the transitioning of care. I'm glad you spoke about it. So are there lessons that we can learn from HIV? Because we also have pediatric HIV, and the transitioning into care maybe is almost near perfect for them. And I would like you to also comment on that. My second question is with regards to education in primary schools for type 1 diabetes. Does your program also facilitate that type of education? And lastly, I would like to talk about the diagnosis challenges, especially now that we see childhood obesity and we are not yet done with type 1 diagnosis. How do you go about it? Thank you.
Thank you for the good and many questions. I'll try to answer as much as I can. So I'll start with not the easy one, but for the transitioning, I know there's a lot to learn in HIV, which we should follow and see what they're doing really, because even when we say we're sending them to adult clinic, somehow they keep coming back. It means there's something we're not doing right. We're trying to do the clinic, adults and pediatrics at the same time, as in one patient being sent at the same time with a physician and a pediatrician, and see after some time if they'll be able to shift to adult clinic. That is what we're trying now. But then, thank for the recommendation. We'll learn from HIV and see what's good we have to learn from there. And for the education in primary school, the school programs on diabetes, and we have, I would say, peer education. There are Type 1 Diabetes Youth Alliance who are doing the awareness program. It's part of these programs in schools. So yes, that program is there of going to school. And So I forgot one question was obesity and diagnosis. Wow, I'll need help on that. I think for type 1, if we increase the awareness of that there's nocturia, polyuria, polydipsia, and just take to the hospital and they do the blood glucose, will manage to get a diagnosis from many kids. I think we still need more awareness. For the obesity, I think my boss will be able to help me out on that.
Yeah, thank you for those interesting questions. I think regarding sustainability, before we started the program, we worked with the Ministry of Health and the local government, and so that over a period of time, there is a transition so that when the donors leave, then we have some sort of a transition whereby these children are not left hanging. And already within the categorization, insulin is a life-saving drug, so it should be available, and we feel that it will be morally, it will not be right to leave them hanging. So I think sustainability part will come. Question regarding the obesity. With obesity, we have still not started seeing type 2 diabetes in children. Probably only 1 or 2, but not many. But it is something which will come in next 5 years, looking at the obesity, the way the obesity is increasing in the children. So I think the prevention will need to start at the primary school level. And I think what we are doing is that together with the Tanzania Diabetes Youth Alliance, together with the other school health programs, we are trying to see how we can put preventive measures at the primary school, introduce some definitive intervention curriculum so that we have primary sort of prevention starting at the school level. So those are the initiatives which are in progress. Thank you. So can we have a clap of hand for the lady? All right. So finally, on my side, I'll be presenting Dr. Rachel Nungu, who is the program manager for the National NCD program with the TDA, and she'll be talking to us about the implementation of the National NCD program going into the primary care, which is the health centers. And after that, Professor Swai will take over as a chair. Next slide.
Thank you, Professor. Good afternoon, everyone. As I've been introduced, I'm Dr. Rachel Nungu from TDA, working as a program manager for the National NCD program. So I'm here to present about what have been the outcomes and challenges during the implementation of the program, especially in the 1 year after we've started doing the main training of healthcare providers. So the implementation of the National NCD program started in 2019, and is a 5 years program which is being implemented in the country. And the aim was to scale up the national response program to bring the capacity to all primary healthcare units. In this time, we are focusing on health centers. And the aim was to focus on prevention, early detection, and provision of necessary primary level care so as to reduce the burden of diabetes and other NCDs in Tanzania. And in implementing of this program, we had different stakeholders, which includes the Ministry of Health, which had come up with a national NCD strategic plan. By then, we are using the second version, which was 2016 to 2020, but now we are currently implementing the third strategic plan, which is from 2021 to 2026. But also the Ministry of Health provide the experts or master trainers for the national and zonal and referral hospitals who assisted in the training of healthcare providers. And from POLA, just the local government, they assist mainly in the provision of ensuring that these services, these trainings are being conducted, but also they appointed the regional and district NCD coordinators who have been helping us in coordination of this program at the lower levels. And from the university and the teaching hospitals, we have subject experts who have been helping us with development of curriculums, which were used for trainings, but also they are the ones who have been used in upgrading the standard treatment guidelines so that they can And then you have TDA, and then the community are the beneficiaries, or you have patients and the people at risk of developing NCDs. So the program projections, from the beginning, we targeted 484 health centers, of which we had to take 2 doctors and 2 nurses per facility. And our concept was having the common triage, whereby everyone who comes to these facilities, they can undergo common triage, regardless of what will be the main complaint or what they come for to these facilities. So we wanted them to be tried at the common triage area, whereby from there they can be channeled to different departments within the hospitals. So what have been the project results throughout the implementation? One will be on the trainings. As I mentioned earlier, the target was 484 healthcare providers, health centers, but at the end, we managed to train 711 health centers across the country. As you can see, there were increase in health centers during the implementation, as every year, every time, the government has been increasing the number of health centers in the country. So they've been upgrading those who used to be dispensaries to become health centers. And as the program, we try to get as many health centers into the training. So as the result, we trained a total number of 968 doctors and we trained a total of 1,407 doctors, 1,378 nurses. Which is way above our target, which was 968 for doctors and 968 for nurses. And from these trainings, we've been managing to have establishment of special NCD clinics at these facilities that have been trained. As before the training, we had done the baseline assessment, whereby only 25% of the facilities had dedicated NCD clinics within their facilities. But after training, it's been noted that more than 80% of these trained facilities have been managed to have the special clinic days where they see NCDs patients. And mostly they've been seeing diabetes and hypertension cases, although we've been encouraging them to see more of other NCDs such as sickle cell and other NCDs. Also, the benefit of having NCDs clinics, like special clinics, for the patients has been reported that they've reduced the waiting time. Like the patients used to be waiting in time with other OPDs patients, like in any other normal days. But since the start of having the special NCD clinic, the patients have been just been attending their clinics, and there's no waiting in line with other patients, especially when they go for the laboratories to check their glucose level, or when they have to do other measurements, because it's their dedicated clinic days. But for the service providers, they reported that they have been improving care to their NCD patients, because now they can focus on their patients, and they have that close relationship with their patients, so they can monitor their health progress within time, as they've been seeing them on a regular basis. Another accomplishment that have been done throughout the implementation of this project was the establishment or strengthening of the triage centers. So now we have triage centers at these facilities. So now the main aim of the training was to emphasize on having a triage within these facilities, whereby we don't miss people who maybe have underlying, like on the borderline of developing NCDs, so that we encourage them to screen all the patients that attend their facilities, regardless of the complaints. So when we ask them to establish a special area within the clinics, so that when the patients come, they can be measured or screened for either weight and height, so they can get their BMI and being cancelled, and also the blood glucose and other vitals taken at the triage area. As you can see, most of these facilities, they have been managed to strengthen their triage area, as they have managed to, even if they don't have a special place, maybe a special desk, but they've tried to use whatever they have so that they can establish this triage area. And they might not be having the proper way of documenting these people where they've been screened at the triage. Some even have these counter books whereby they put records of their patients or people who they've been screened at this triage. So here they can record the BP, the blood pressure level, and body weight, and BMI For most of these health centers, the RBG, the glucose level measurement is being done at the laboratories, because there they have to be measured and they have to pay for that test. So it's mostly not done at the triage. But also through the program, we've been able to provide screening tools for basic screening of NCDs, and these tools they've been used by these facilities, and they've been able to they enable them to provide immediate and efficient services. As one of the nurses from Kuz Health Center reported that now that they have their own equipment, so if they need to measure patient blood pressure or blood sugar, they don't have to go to another room. Or if they need to measure weight, they don't have to go to RCH for those measurements, because now they have the tools right where they are at the OPD, where they have placed the triage center. As you can see, these are some of the activities that have been going on since the implementation of this project. There are some of the health centers that when they went back right after the training, they went back and put these big posters of what they will be the available services concerning NCDs within their facilities. So as you can see here, we have Kituo cha Afya Inyonge, like Inyonge Health Center, Inyonge Health Center, where they went and put this big poster in front of their hospital, like explaining what are the clinic days, the dedicated clinic days, and what kind of type of NCDs that you'll be seeing during those days. But also on the right, we have this screening activities going on. This was an outreach where people have been going out on outreaches so they can continue with screening of patients in the community. But one of the things that have been reported by this facility that have been trained was lifestyle modification counseling. This has been done to all patients that have been attending OPD and those who have been diagnosed with NCDs. So previously, when patient used to come and they've been diagnosed with NCDs, they usually to start medication right away. But now, since through the training and the advocacy, so the healthcare providers, now they provide the lifestyle modification counseling before they can initiate medication if the patient does not improve their status. But also through the OPD, they've been starting this counseling and education to patients who have been visiting OPDs. But also now they have increased availability of NCD tracer medications, as we've done some assessments, and most of those tracer medicines for NCDs are available in most of these centers that have trained. And this has led to reduced referral to higher facilities, because now they only refer complicated cases. As you can see here on the left, this is the letter from the Ministry of Health that since now they know that you've trained providers from the lower levels, now there's some of the medication that have been taken to lower levels, because now they know that the healthcare providers in these areas, now they're capable of using this medication and prescribing this medication. So this was the letter on the cardiovascular medications that have now been taken to lower level of primary health care. But previously they used only to be provided or prescribed at the district level. But since now they know that these providers at the lower level, they've been trained and are capable of using these medication, prescribing them, so they've been lowered to their levels. But also on the right, you can see some of the medication that have been found at the facilities, because from the training, they've been emphasized on how they can do their stocking of NCD medicine, how they can order NCD medicines, like maybe these are essential or tracer medicine that should not be missing in their centers. So you can see now they have full stock in most of the centers. But also now they have posters. Previously, we never used to see NCD's posters in primary health centers. But now they have put a lot of posters. TDA have managed to supply some of these posters, but as you can see, they're encouraged to even put them at the mapokezi, at the reception area. So when people go there, they can at least see what is going on about NCDs. So they can learn or they can ask more questions. So what have been the best practice that we picked up during the assessment of the implementation? One of them was the initiation of diabetes patient clubs. In some of the places, especially in Moshi, we noted that there are 2 centers that have started diabetic patient clubs, and this is to ensure that the patient, when they go to the clinics, they get the blood sugar tested. So the members of this diabetic club, they They contribute money so that when they have enough money, they give to the hospital so that they can purchase the blood glucose strips. So when the patient goes there for their NCD appointments, clinics, they find the strips available for them to continue with their treatment and management. But also this club, they've provided peer health education, whereby the experienced patients are now educating the new patients that have been found to have diabetes. So what have been the challenges so far is that some of these health centers, they don't have big rooms like at the OPD, so that it's very difficult for them to set a triage center, as we can see in the previous photo, whereby they just used that a cutter for them to put those equipment for the triage. So in most of these health centers, they just have one room where they have to use it for dedicated NCD clinic and to see other patients. So this has been very difficult for them, especially when they want to have the specific or dedicated NCD day. But also another challenge has been the staff attrition of healthcare providers and NCD coordinators. For healthcare providers, we may find that those who have been trained on NCDs, some of them, they've been moved or shifted to maybe to other departments within the same hospitals, or they've been moved to other health centers or other centers in different areas. So this has been affecting the consistency of providing better treatment or quality of care to our NCDs patients as they've been moved around. But also, the majority of NCD patients cannot afford the NCD screening and medication cost. As I mentioned earlier, most of the blood glucose, the sugar level have been tested at the laboratory, whereby they have to contribute like some little contribution, but most of the patients, they cannot manage they cannot afford. So this has been discouraging them, and also they cannot afford the medication. So most of them, they've been have poor adherence to medication or loss of follow-up to their clinics. But also we have limited resources to conduct community outreaches. Most of these trained healthcare providers, they wish to go to the community. They wish to visit people in the community so that they can educate them more about NCDs and ask them to come to their facility for more screening and more. But since there is resource limitation, most of them, they just end up just capturing the people who are just coming to the facilities. But another challenge, as I mentioned, there's a lack of space, enough space or room to accommodate a designated NCD clinic. As you can see, this is just one OPD room in that facility, whereby they have to see NCD patients, they have to see other OPD patients, so it's very difficult for them to figure out on how they can divide the days for NCDs. But so what have been the recommendations so far that the program will recommend after they've seen the implementation of the program so far? One of them will be the strengthening of data system so as to capture NCD data. But I failed to mention earlier, but one of the major challenges now we have is that there's no clear pathways, there's no data pathway in how we can collect NCD data. It's very different from how CTC operates. It's very different on how RSH, Mama na Mtoto operates. But in NCDs, there's that breakage of data. Those are one which are on HMIS or HIS2. They don't capture everything that we wish to have. And then there's most people, they don't use, especially at the primary health centers, they're not computerized. So they use mainly to write in those Mtuha book where they fill in. So that becomes cumbersome for most of the healthcare providers. So they find it is a very hard job for them to note down everything they see on NCDs. So that leads to lack of data on NCDs. So wish this data system could be strengthened so we can capture the NCD data. But also, we need to have continuation of trainings. As I mentioned earlier, there's staff attrition where people have been moved from one place to another. So as to have the continuation of care to these patients, we need to have continuous training whereby everyone at the facility can have knowledge on NCDs. Once they have knowledge on NCD, anyone can take part when they come to treating the NCD patients. So we don't have to wait for those who had gone for training to come to see the patients. But also we need to see the integration of services from the RSH, CTC to NCD. As I mentioned earlier, our main aim was to have the common triage concept, but that thing is still missing. People have been screened at CTC, where now they've been screening for diabetes, they've been screened for BMI, where to see if they're obese, but those information that ends up at CTC. People have been screened at NCD clinic for all the same things, but there's no that linkage between these two services. Or with RSH, we might be having gestational diabetes, but that's not being captured because it ends at RSH. So these steps they need to be integrated for to have the patient-centered approach, as we are all treating all seeing the same patient or the same people. Another thing was strengthening supportive supervision and mentorship on NCDs so as to continue having the quality of care that we are all advocating for. And another recommendation was to have budgeting for NCDs in the council plans and facility plans. This will help us at least to make sure that we have enough drugs or medication for NCDs in place. They have proper budgeting for the outreaches and so forth. So we hope with this recommendation, there will be improvement within the implementation of the NCD program, and we'll see better outcomes when you come to assess the program at the end of the program. Thank you so much. I'd like to acknowledge the WDF who have been the main sponsor of the program so far, and the Ministry of Health through the NCD program, and PRH who have been the backbone of the implementation of this program. Thank you so much.
Thank you very much, Rachel. And any questions? Hypoglycemia, tiredness, or it was very crystal clear? Yes, please.
Thank you very much for the good presentation. I saw in your presentation one of the challenges which people face is no money for NCD screening and medication. I was wondering, don't you have health insurance here in Tanzania? Or isn't it why don't they access if there is a health insurance? I know cost sharing sometimes it is very hard out of pocket, but at least I wouldn't put it as a gap. I would say that due to cost sharing maybe is not making people to access screening and medication. So I want to know.
Any other question? Yeah.
Yeah, hi, I'm Stefan Islandi from the Danish NCD Alliance. Thank you for a nice presentation. Just wondering, when you've done these groups at lower level for diabetes patients, have you then come across or heard that other NCD groups are requesting similar group setting, a similar setup? Just wondering what you heard about that.
Thank you for the wonderful presentation. My name is George Msengi. Just have a bit of a point to share, especially on the issue of the recommendation, strengthening the issue of data, and especially on the output side of data. This is such a great program. We see a lot of people being trained, but I think for the stakeholders who are here, there is more that can be done. There was a picture you shared on a notebook, and the clinicians writing down the patient information in terms either of the output, how the management, or probably the prognosis is going on. So I think this just as a point to share, we've been trying to work on data registry, NCD registries for some time, but also just as another point to share that another alternative route apart from population-based registries is individual tracking. And what do I mean by individual tracking? Probably a clinician on their own can have, rather than writing like that, it is very hard to have the analytics of the information that you have. I have visited Professor Kaushik several times and seen on his computer, he has the trends of his patient, and I would just like to call upon stakeholders, if you are a clinician or rather an organization that deals with data, providing a platform in which clinicians can actually see the progress of either the medications they provide or the progress of the management of the patient, I think is very, very mandatory, especially to a nationwide program like this. Thank you.
Thank you so much for your good question. I'd like to respond the first question on the insurance scheme. Yes, we have various insurance schemes in the country. The first one, we have the national insurance scheme, but then we have those local ones, the CHF, the community health funds, where people contribute only like, is it only almost $12 a year? But you won't believe that majority of people are not on these schemes. They're not on insurance schemes. And when you come to these schemes, most of the medications, they're not even in the scheme. So they are told to go and buy outside the facilities. So they end up back to the same problem. So we have been encouraging people to have this insurance scheme, so at least they can get this checkup, like a diagnostic checkup, like when they go to the laboratory, if they've been sent maybe for x-rays, for ultrasound and so forth. But it's now we are singing another song of universal health coverage. So I hope maybe with time that will be the thing that is going to help us move from this, where we are now, to where we need to be in terms of insuring of NCD patients. So there is no much people in this insurance scheme in Tanzania as we wish them to be on. And most of these patients, especially those who are or above 60 years of age, those are older, they are supposed to be exempted from treatment. So you might receive exemption, but when you go there, you're told that there's no medication, there's no this, so go outside. Go to the farmers outside for you to get this medication. So it also become a problem for these people to ensure that they have proper treatment or management. So another question about the clubs. Yes, we've seen majority of them being diabetes clubs. I've never come across any other disease group that needs to be, but we have other we have other clubs that have been coming up, like initiative that have been done by people with this condition, that have been trying to look for actively looking for other people with the same condition where they can unite together. For example, we have sickle cell, where we have those champions that have been trying to bring together the people who are having the same condition so that they can have their own unity. And so these are not basically for them to have to contribute money to have maybe to receive some medication, but majority are there for education, to propagate education to other sickle cell patients of the community. And also have people living with NCDs, like it's like a group association of people living with NCDs, whereby it brings together different people with different NCD conditions, regardless if it is diabetes, hypertension. So when they meet, their own agenda is advocacy for different diseases within their association. So far, those are the kind of initiation that we have for other disease apart from diabetes. Thank you.
Thank you very much, Rachel. And let's give her another clip. And Professor Swai, please. Yeah.
Thank you, Professor Kaushik. I'm now your chair for the remaining part of the session. Now, the way the program started in Tanzania, we started the training at the higher levels, the regional hospitals, the zonal hospitals, because NCD training in the medical schools, you have 1 hour or 2 hours on diabetes, 1 hour on hypertension, and that's not enough for you to practice on. And that's why we thought the training was necessary, but then we wanted to start at that higher level rather than at the lower level. If you train people at the lower level and then they refer the patients up and the top is not prepared, it will create problems. So we deliberately started. We have now clinics in all the regional hospitals, all the zone hospital, regional hospitals, and district hospitals. And the one the last presenter presented is now going down to the health center, which is the topmost level in primary health care. Now we want to go further down to the dispensaries and to the health centers, and the dispensaries and community health workers. So the next presentation is on what we think should happen at the community level using the community health workers. So may I call upon our next presenter to present. and that is Dr. Josephat Kamugisha.
Good evening, everybody. Yeah, I'm going to present Diabetes Compass Project. It is funded by WDF and implemented by Tanzania Diabetes Association. And the project it has two managers. I have my manager colleague, Geoffrey Mwakijungu is there. So in case of any question, of course, he will respond. So this project in Tanzania, we have two regions. We have started with the coastal region and the Lindi region. We have almost 8 health facilities as a pilot area where we are going to implement digital health to make sure that we can manage diabetes properly. So let me just go, as you see here, Diabetes Compass, we are seeking to reduce the vulnerability along with the diabetes care pathway by developing innovative digital health solutions that support healthcare workers and people with diabetes in their daily efforts. So we are expecting that this project, healthcare providers and the community people, they can just have the capacity to manage themselves, the people at the community setups, and then the health provider can be more innovative to make sure that can manage diabetes at the health facility. As you see here, we have Diabetes Compass. The aim is to support vulnerability reduction and drive care optimization to improve the lives of the people living with the diabetes. Here we have the stages. We can see we are expecting to have primary prevention, and we are expecting to have risk detection, and we are going to have diagnosis and the assessment, and we are going to have care initiation, self-care support, care advancement, and manage complications. We are expecting that people themselves at the local setups, they can just even manage themselves, but also with the support of health providers. This graph does not mean just inform anything here. It is just a journey to show that how we are going to start and just go like that, but not just in the scientific reasons. So, this project has been launched to the countries. You can see here, we have Tanzania, we have Sri Lanka, and you have Malawi as a startup. And you are expecting that this project will just be scaled up to across of all the nations. So for Tanzania, as we have started with 2 regions, we are expecting that after this achievement, then we are going to scale up to another regions. So in 3 countries, we are sure that we will start and then we will just go to another countries again. As I have said that Diabetes Compass, it is just working under WDF, World Diabetes Foundation. They have the partners or network, people who are just working together, the expertise. You can see RTI is there for just research, and the other partners, I cannot mention each partner and how we just support. But these are global partners, but also we have strong local partners, really to strong local ownership. Here in Tanzania, we have Tanzania Diabetes Association, we have Ministry of Health, PRORAG, and Tanzania NCD, Prevention and Control. We have MUHAS. MUHAS, they are supporting us in the evaluation and the monitoring as well as the research during the implementation of activities. Also, we have HISP, Tanzania, and the WDF. These are local partners, really to strong local ownership. So we are expecting to really just achieve with these partners. We have innovations. We are saying that the diabetes compass follow needs-based design approach for developing digital solution. And we just expect to have two approaches. We have traditional approach and we have needs-based design approach. For this project, we have just considered about identification of problems and needs. That approach which I've just scaled out and they go together. So we are just looking how we can just leverage the promise of the technology to address these issues after just identifying the problems and needs. Also, we have 4 opportunity spaces which we have just identified and see how can we just work to make sure that we can achieve this project. But therefore, because of the time and the resources, we have just selected only just 3 spaces. We have health information. Here we want to strengthen the diabetes care pathway by strengthening health information capture, transfer, and use. So we are working with the government to make sure that we can just strengthen the health information system. Also, we have the early detections, where we have strengthened the diabetes care pathway by improving early detection and the timely diagnosis. Here we are expecting that community health workers, they will get training, they will get just instruments, tools to make sure that they can just screen people at the community level, at household. And then for those who reveal to have the high risk, they can be transferred and referred to the health facility. And we're expecting that healthcare providers will have the system where they can just know how many people have been transferred or just referred from the community to go to the health facilities. So the unit will understand clearly that all the people who have been referred will just reach to the health facility. If not, then the community health workers just make follow-ups. Also, we have another opportunity. We have healthcare provider learning and the performance. We are expecting to build the diabetes-related clinical capacity among the clinical officers, nurses, community health workers at the level of the primary health care. Also here we have the diabetes compass solution development takes place at the 3 distinct levels. As I said, community levels, we are expecting to have a community health strengthening platform where we are going to have the tool. It is just in the process to make sure that they can just support. Also, we have facility level, case-based electronic medical records. We are going to use the Gotomis government health information system, and it is application which is just going to be working with it's just under the government, we were there, just be implemented as a standalone, but now it's going to be central, so it will be just controlled by the government at the central level. So we're expecting that person who will be diagnosed with diabetes and he get treatment, maybe he's in South region and he go to North region, can just access treatment, and then it can be just when you just go to Kigoma or other regions, can just be all the information will be captured in there, and when you go to the health facility, I think the information will be there, and then you can proceed with the medical doctor. Also, we are expecting to have a national health system for aggregate data management, DHIS2. So this Gutomis, you can say Gutomis in just abbreviation, it will be just transfer the data to the DHIS2. So we're expecting that all the information will be just there, and you can just take the information and manage the cases. Also, we have digital solution for health information. Here, we have data capture, data transfer, data interpretation, and data use. This is the system which will be used by the government. Government health information system module, we have strengthened the information system with the government. So this application, I think there is no need. The way clinical officer, medical doctor will be use this application to fill the information of the client when he just got the facility. It does not take more than 5 minutes to make sure that at least you can just treat or manage the best case at the health facility easily without having some kind of just delaying or just wasting of the time. Here we are going to the digital solution for error detection. In that approach, we are expecting to educate screeners future trained screeners learn how to perform outreach and diabetes screening. As I said before, that community health workers will be just working from household, family, and in the community as well to make sure that they can just make screening. After screening, then they can just refer the patients, the people who are at risk. And then we are expecting that they will provide screening opportunity at the community level. Also, they will conduct screening with the application, not just using the papers and just pen. No, they have the phones, they have everything, and they have tools. They can feed the data and then they detect people and then send to the health facility. Also, we are expecting also to send out appointment and a reminder, so all the kind of information will be available to make sure that that person who has been referred cannot just lost in the street. This is a community sensation campaign for early detection. We are expecting to use the banner, leaflets, flyers, announce about identification of diabetes early stages and make go to the health facility. So these are leaflets we are going to use. Community screening too, it looks like this. The community health workers will be using this. It will be in Swahili language, not just in English like this. But we'll be just maybe just looking how we can just make amendment in case if there's something else. But it's in the process of just development. So it looks like this. Here we have digital solution for learning and performance support. We are expecting to have courses, resources. We are expecting to have mentorship program and ebook. We need to have the health providers just to have the program where they can just read without need just internet. They can just read. We have application. We are going to have an application to make sure at least our staffs, health providers, they can just have information there. And then it looks like this application. It looks like this to make sure that they can just get information at home, in the health facility, at work, and everywhere. They can just get information how to manage diabetes and hypertension. This is the roadmap and the key milestone of the outcome of the individual and diabetes compass within the opportunity space in the 3 launches countries. Here, I think we can see we have early discussion, define, develop. We are in the stage of develop. We have already just developed and deliver. So we are in this stage. As Tanzania, you can see here, we have health information started December. So we are on track and we are expecting to accomplish very well. Here we can say that there is a great fit between the vision for diabetes compass and Tanzania primary healthcare digital transformation. This is the key priority to align our work with the national strategies and priorities such as this is a government strategy. So we are not going just to do our own application or our own activities. We just follow the government strategy. The government, they have the strategy 2021 up to 2026. So we can just, this is a government strategy which are using this to make sure we can just do this work. Also we have, what have we learned so far? We have local capacity as a key. There is often a shortage of specialized technical capacity in developing countries as a part of the project building up local capacity in critical to ensure sustainability of solution. And also there is ensure that the capacity building is built into all aspects of the program from the beginning to ensure implementation teams are capacitated from the start. Also here we have technology development in the highly dynamic field. You can see it requires flexibility and solution-oriented mindset to design and develop in an environment that is constantly changing a new technology. Opportunities and development will appear along the way. So these are things we have just observed. Also, there is a co-creation approach. Solution development takes time and therefore significant resources to support the processes. We have deliberately did not want to bring in exciting solution and try to make them match the reality in the country. Although this will be an easier route to take, it's not the most sustainable in the long run. I can say thank you very much for your attention.
So that's the program in making. I think the software should be ready by end of December or so, or before end of December. And then the program fully starts next year. Any questions?
Thank you very much. And these are excellent initiatives with the Tanzania Diabetes Association. My name is David Makome from the NCD Alliance Kenya and also East Africa NCD Alliance. My question is very generic. With all the initiatives, the digital solutions, Compass, and all the Diabetes Food Project, pediatrics, and all these initiatives, is there a point of convergence? At what point do all these initiatives and programs converge? Where is the intersection? Maybe, and how do you avoid things like duplication?
Hello. Can I go ahead? This way? Yeah. Okay. Yes. My name is. This one works, I think. Yeah. So my name is Ferdinand Sonyoy from Cameroon, working with the Africa Institutes Network. And so just recently, we had a digital roadmap developed by the World Heart Federation, which really showed roadblocks to uptake of digital health solutions. And I think it will be very, very relevant to look at that because some very key, for example, acceptability of digital solutions by healthcare providers is a very serious challenge. And sometimes it looks as if when you bring the digital solution, you're actually either wasting the time of clinicians or they themselves feel like they should do something else. So I think it's a good resource for you to look at, especially because it's recent and it really provides some very updated information about the challenges in the uptake of digital solutions for NCD prevention and control programs. Thank you.
No other questions?
Okay, thank you. My friend from Kenya, you have just mentioned things like duplication of what we are doing here. We are not just developing any application from outside of the system of the government. We are going to strengthen the health system which is inside of the government. In the government, as you said, we have health information system, which already we just in implementation, which is called the GUTOMIS. That GUTOMIS now is going to be strengthened. It will just be working just central, where the basic compass, we have just put the component of module, which is called the module, diabetes and hypertension, which will going to be separate with the NCD. So in that case, we are not going to just to develop anything about the application which is out of the government system. So we are happy to say that the government, we are working very collaborative, and they have agreed, and we are in the final touch to make sure that the application is strengthened and it can capture all the information of the person with the diabetes and hypertension, and it can be just treated and managed at all places in Tanzania. Thank you. Another one is just roadmap, the person, my friend from Cameroon. Thank you very much for observing this. We have a challenge in Africa, of course, in health providers, especially in the digital health. Sometimes they have the behavior, and it looks like people, they have experience of paperwork instead of just using the digital, just computerized things. They don't want sometimes. So we are going to train them and change behavior a little bit and the attitude to make sure that they can work together, because at the end of the day, this will help, because if you use the paper, you can roast your client or your patients when you go to another place in the region or districts. So and I understand that's a big challenge, but we know that we are going to work with the government to see how we can change the attitude of the people so that they can just use the digital as a solution of the managing of the diabetes.
Thank you very much for the presentation. I'll call upon the next one because of time. We've already gone through the time. When COVID struck, many of the people who were affected badly were the people with the NCDs, diabetes in particular. And many of the early days were people with the diabetes, with cardiovascular disease, etc. And so we thought we needed someone to, how do we manage acute emergencies? And that is the next presentation. Dr. Mashompo, please.
Hello? Are you there? Being the last person, I'm sure everybody will look at me and we have few minutes to time. Yes. May I start now? Okay. I'm going to take you through the training of acute care management that we did in the era of COVID-19 in 2020. I'm sure in that period, if I'm not very mistaken, everybody knew what was happening in the country, whereby everybody was running away wherever I see a patient who is having a labored breathing status. Now, just to tell you, is when COVID came in, very few of us were very prepared to handle cases that were coming in very big numbers in a very short time. And for that matter, people were dying, and we didn't know exactly what was the best management at that particular time. But that not being the least, we thought there must be something that should be done right away. Just to tell you, for the few who were referred, who came to our facilities in Dar es Salaam in particular, you come for one facility with the labored breathing or difficulty breathing and the like, because of the COVID which was killing so much, they tell you, go to Mloganzira, they tell you, no, that is not to go to Mloganzira, you have to go to Amana. Before you go to Amana, they tell you have to go to somewhere else. You know, in that going around and going around, the condition of the patient is worsening, and at the time you reach to a facility, you are at the terminal end. Now, the project which managed to reach this point that we are talking of the training of the trainers was on NCD COVID in particular, and it was supposed to be implemented in Dar es Salaam. But being in the favor of what was happening with Dar es Salaam, there were so many patients by then, but again, we thought Dar es Salaam, as it is, it cannot stand alone. That was a city, is a business city whereby interaction was so much. But we started with Dar es Salaam, and we managed to train people to the capacity of handling emergencies as far as NCD and COVID was concerned. The Dar es Salaam management and the committee, the steering committee of the project looked at it further. We said we should start with the Dar es Salaam, okay? But again, Dar es Salaam is not standing alone. The other cities which are experiencing similar difficulties of managing these patients, and their populations are great. We thought we should really look forward to look Dar es Salaam as a pilot, and in the so doing, we train people, we train healthcare workers at their from district and the regional hospitals who will train others at their health facilities, in particular health centers. And these were for professionals who would check out the vaccine. The institution who would be told to be quite extended to read the method of the graphic. We went through 3 of our package that will take all these cases in a minute. This is very valuable. You know, the second that included the Ministry of Health. I'm sure Kakari there, we were there for time. For us, in the case of the residents and the professionals from different associations, the MAT, EMAT, APA, and the like. We developed a national master training for acute care management. This was a team which was really professionals that were ready to manage acute care conditions. TDA and DPHA came in terms of community awareness and the like. Including the AFTA, we also trained some people from getting awareness from AFTA, though they were not ready, but they were trained, including the Christian Social Services Commission. The TDA and the one person who is my colleague is not here yet. He really went around to find out how best can you establish the master trainer team. And this master trainer team should come out. Emergencies and the surgical emergencies. We also thought it was important to talk of professionalism and ethics. I'm sure you're all aware that some people are not really working to their capacity and to their dignity. You see? Ethics are almost at many places very much down. How best can you deal with a patient who is really in acute state in very bad condition? Now, the methodology that was applied here was very much interactive. There were presentations, discussions, and practical sessions. And the language was quite simple in this training manual, training package. Simple English and simple Swahili with a lot of interactions. We had the pre and post tests that would assess to how much is the capacity, how much knowledge has gained for those who went for the capacity building workshops. See here, we're in trainings, and the training here was involved the 4 regions of Kwanza, Dodoma, Arusha, Dodoma, and Mbeya. With this, we had sessions of training, which was really practical. The
up in one of the facilities. Now, the development of a master training team. After having developed this team, we have managed to train up to 200